Yes, this is for you. I'm starting the timer and here is the question. If you have read and understood, considering it communication skill station, kindly please begin.
Okay. Hello, I am Dr. Ali, one senior house officer, doctor for working for Mr. Man at Royal Hospital. I am calling to speak to the general surgery consultant on call to ask him advice about our patient who underwent right hemicolectomy and now she has been oliguric. May I confirm that I am talking to Mr. Ahmed?
Yes, I am Mr. Ahmed. Summarize your
Okay.
case.
Good.
Okay, our patient is 69 lady presented after she had underwent right hemicolectomy for cecal cancer, cecal tumor 24 hours ago. Follow-up on the patient showed some tachypnea and hypotensive. Reviewing her urine output relieved that she has only 10 to 20 milli per hour over the last 8 hours. And also the labs of the patient showed drop around 2 grams of her hemoglobin. Regarding that, also some labs of her urine, her renal function showing elevated. For that, we need your advice about this case.
Okay, did you check the urine catheter? It may be blocked.
Yes, I checked the urinary catheter and it is not blocked.
Okay, what do you think the cause of this oliguria?
Regarding the intraoperative notes of the patient, they show some blood loss during the operation, and she already received only 2 units of blood during surgery only. And after that, the flow chart showing that she only received around 1 liter and 100 milli of normal saline over the 24-hour after post-operative day 1. So I think we can go for dehydration. Keeping in mind also she has drop hemoglobin due to this, maybe due to the blood loss in the theater.
Okay, so what? How you manage this patient?
So based on what we have, the patient may be dehydrated. We start fluid resuscitation first. We can start for as the patient is old age and we have past medical history of cardiac, we can go for only 5 meter per kg. And after that we assess and look if the patient shown some improvement or not. And we can also take labs for the patient and repeat it. And we cross-matching some blood maybe need next few days. Cross-matching for blood transfusion.
Okay, so what will you do if the patient didn't respond for the fluid challenge?
Okay, after failure of flow challenge, we should notify the high dependent unit registrar, considering to may insert a central venous line and start some inotropes and reassess after that.
Okay, do you think the patient may have an active bleeding?
Maybe after this major surgery and dropping her hemoglobin. But with serial abdominal examination, his abdomen is soft, is not tender, no signs of intra-abdominal bleeding, and we sure arrange some investigation like ultrasound to see any leakage in the abdomen, and I will keep eye on her abdomen and we notify you and update you.
Okay, what else you will conserve to ensure that there is no abdominal bleeding, except the abdominal examination?
Her labs, we will repeat her hemoglobin and keeping eye on if it is dropping or not.
And what about clinical? Any clinical signs?
Any abdominal change of color, coin signs, any tenderness, peritonism of the hair abdomen, rigidity, any sign of peritonism.
Okay. Do you think she have an anastomotic leak?
It may be, but the patient abdomen is lax, showing no rigidity or no rebound rigidity. So we will keep for serial abdominal examination. And also the patient have no fever, no signs, the workup of sepsis is not elevated.
Okay. Do you need me to come back?
I will start my flow challenge and I will keep you updated what will happen.
Okay. Thank you.
Okay, thank you.
Do you think patient needs to be transferred to a high dependency unit?
Till now, the patient we can consider a transfer if no response for fluid challenge.
Okay. What would you do if a high dependency unit is full?
Now we will arrange with the bed manager to facilitate repartition or facilitate easy discharge in stable cases from any department.
Okay. What do you think might be the cause of shock in this patient?
It may be hypovolemic shock due to blood loss or due to the decreased intake of the patient as the patient's old age and go through major surgery and his oral intake and his replacement is not adequate enough.
All right. If patient
And
has,
also
yes,
we
yes, please.
maybe consider it septic shock, but it's not it's too early to say that there is some septic focus.
Okay. Right. How would you, what would you do or how would you proceed ahead if you suspect that patient can have air embolism?
If
So oxygen
you suspect of,
saturation drops, yes.
yes, if we suspect of pulmonary embolism, we should assess the patient regarding ABCD CRESP protocol and assuring that his airways in adequate and his breathing going well and stabilizing hair circulation and for seeing his blood glucose level and response with eye. After that, we should go for some laboratory investigation like D-dimer or fibrin degrading
yes.
factors and CT pulmonary angio.
Oh, yes. Good. This is what I wanted to hear. And TED stalking maybe. Okay, good. Then you can transfer the patient. Thanks.
Okay, thank you.
Right. Good. Thank you. Excellent.
Thank you.